Usually when we talk about a symptom, it's something you feel privately,
Right.
like a sharp pain in your side, or maybe a dull ache in your joints, or, I don't know, a sudden chill. It's an internal experience that you really have to describe to someone else.
Exactly. You have to find the words for it.
Yeah. But then there are those symptoms that just announce themselves to the entire room before you even open your mouth. You look in the mirror or like a loved one looks at you, and suddenly the whites of your eyes or your skin are glowing this undeniable neon yellow.
It is, it's incredibly jarring. I mean, it's one of the few medical signs that is visibly obvious from across the room.
Oh, absolutely.
People will often rush to the emergency room in an absolute panic because they're convinced their body is permanently failing.
And honestly, that panic makes total sense, which is exactly our mission for today's deep dive. We are decoding jaundice.
We are indeed.
We've got this massive stack of clinical notes, pathophysiology texts, diagnostic workflows, and nursing protocols right here on the table. And we're going to break down the mechanics of this whole phenomenon for you.
Because there's a lot to unpack.
Right, because here is the biggest misconception we need to clear up right away for you. Jaundice is not actually a disease.
No, it's not.
Yeah.
It is a glaring yellow warning light on your body's dashboard. It basically tells us that something else in your internal machinery has gone completely off the rails.
Yeah, like an alarm.
Exactly like an alarm. It's a physical manifestation of an underlying disorder, not the disorder itself.
Okay, let's unpack this. What exactly is this biological paint that's turning the skin, the mucous membranes, and the sclerae, which are the whites of the eyes, yellow?
Well, the clinical term you'll see scattered throughout these texts is hyperbilirubinemia.
That is a mouthful.
It really is.
Yeah.
But broken down, that just means an elevated level of bilirubin in the blood. And bilirubin is this heavily pigmented yellowish-orange substance. So when the levels of it build up in your bloodstream, it has nowhere to go. It eventually spills over and deposits right into your tissues, effectively dyeing them yellow from the inside out.
Wow. But, to figure out why it builds up in the first place, we have to trace it back to the source, right? We need to look at the normal life cycle of bilirubin.
We do.
I was reading through the physiology section of our sources, and the whole process really reminds me of a highly efficient biological recycling plant. There is this very strict assembly line that handles waste management.
I actually really like that analogy.
Yeah.
The assembly line has 4 distinct steps, and it actually begins nowhere near the liver.
Wait, really? Where does it start?
Step 1 is production, and it starts with your red blood cells. A normal red blood cell has a lifespan of about 120 days.
Oh, right.
As they age, they get stiff. They can no longer squeeze through the tiny capillaries in your spleen, so they literally break apart. And when they break apart, your body dismantles the hemoglobin inside them, the protein that carries oxygen.
Oh, I see. And one of the byproducts of dismantling that hemoglobin is our yellow pigment, right, the bilirubin.
Exactly. Specifically, unconjugated bilirubin or indirect bilirubin.
Right, and unconjugated basically means it hasn't been processed by the plant yet. It's just the raw, untreated waste material.
Which brings up a massive logistical hurdle for step 2, which is transport. This raw, unconjugated bilirubin is fat-soluble. It is not water-soluble.
So it can't just float in the blood.
Right. It cannot just float freely through your watery bloodstream to get to the exit. If it tried, it would just clump up. So it needs a dedicated ride.
It hitchhikes on a protein, right? Albumin, I think it was.
Yes, albumin. It acts like a biological delivery truck. It binds tightly to this fat-soluble waste and drives it straight through the bloodstream to the liver.
And then the truck arrives at the liver, which initiates step 3, conjugation. Your liver cells, the hepatocytes, act as the actual processing plant.
Precisely. They pull the raw, unconjugated bilirubin inside, and they chemically attach it to something called glucuronic acid.
And that chemical reaction is the absolute magic of the whole process, right?
It really is. By attaching that acid, the liver converts the bilirubin from fat-soluble to water-soluble. And we now call it conjugated or direct bilirubin.
Because it's water-soluble now, it's finally safe to move without a transport truck. It's ready to be flushed out, which is step 4, excretion.
Exactly.
The liver pushes this newly conjugated bilirubin into your bile ducts. It travels down your plumbing into your intestines, mixes with your stool, and leaves the body.
And an interesting side note here, as it travels through your intestines, bacteria break it down even further into a substance called stercobilin.
Oh, yeah, I read about that.
Yeah, that stercobilin is actually what gives normal human stool its brown color.
I just love how mechanical the human body is. So if we connect this to the bigger picture, a disruption at literally any of these 4 points, production, transport, conjugation, or excretion, is what causes bilirubin to back up into the blood.
You got it. And that backup is what creates the yellowing we call jaundice.
Which is why clinicians use this fantastic mnemonic to quickly assess what's going wrong. They call it the 3 Ps of the jaundice pipeline: production, processing, and plumbing.
It's a great tool. When you see a yellow patient, you are basically asking yourself, is this a production problem before the liver, a processing problem inside the liver, or a plumbing problem after the liver?
Okay, let's break down those 3 Ps, starting with the first one, a production problem. The medical texts call this prehepatic or hemolytic jaundice.
Right.
This is when the liver is perfectly healthy, the processing plant is open, it's fully staffed and running on all cylinders. But the delivery trucks are dumping millions of tons of waste at the front door all at once.
Yeah, a plant is completely overwhelmed. There is a massive, excessive breakdown of red blood cells happening out in the bloodstream. Step 1 just goes into dangerous overdrive.
Wow.
So the liver simply cannot process the sheer volume of unconjugated bilirubin arriving at its doors.
I was looking at the risk factors for this, and it's a wild mix. You have genetic conditions like sickle cell disease or hereditary spherocytosis.
Right, those are big ones.
In those specific cases, the red blood cells are manufactured with an abnormal shape, so the spleen actually thinks they're defective and destroys them way before that 120-day mark.
Exactly. But then you also have environmental triggers, like malaria.
Yeah, walk me through that. How does a mosquito bite lead to yellow eyes?
Well, the malaria parasite gets injected into your bloodstream, and it actually invades your red blood cells. It uses them as a sort of incubator to multiply.
Ah, that's wild.
Yeah, and eventually the parasite load is so high that the red blood cell literally bursts open, releasing more parasites and spilling all that hemoglobin into the blood all at once. The body is just suddenly swamped with raw material.
Okay, so that perfectly explains what happens when there's too much trash for the recycling plant. But what if the amount of trash is perfectly normal, but the workers inside the plant go on strike?
That is our second P processing, hepatic or hepatocellular jaundice.
Right.
The raw materials are arriving at a totally normal rate, but the factory itself is damaged. The liver cells, the hepatocytes, are inflamed, scarred, or actively dying.
So they just can't do their job.
Exactly.
Yeah.
They lose the ability to take up the bilirubin or to attach that glucuronic acid to conjugate it or even to push it out.
And this is actually a great moment to remind you listening, if you've got a bad back or a lingering headache and you are popping over-the-counter acetaminophen, like Tylenol, like candy, you really need to be careful.
Yes, absolutely. Acetaminophen toxicity is a huge cause of drug-induced liver injury. You are directly stressing that conjugation plant in your liver. I mean, it is not just a harmless pill.
It's a major risk factor, alongside excessive alcohol consumption leading to alcoholic liver disease or viral infections, like hepatitis B and C.
Right. In all these cases, the liver tissue is under assault. The factory floor is essentially shut down.
Which brings us to the final P, plumbing. Post-hepatic jaundice, which is frequently called obstructive or cholestatic jaundice.
Yes, the plumbing issue.
In this scenario, the blood is fine. The liver worked perfectly, the factory did its job, the bilirubin was conjugated and made water-soluble, and it's all packed up and ready to leave the body. But the exit road is completely blocked.
The bile flow hits a literal wall somewhere in the biliary tract. And because the conjugated bilirubin can't move forward into the intestines, the pressure builds up.
It just backs up.
Yeah, it backs up into the liver, and eventually the pressure gets so high it just overflows right back into the bloodstream.
And the culprits here are usually physical roadblocks, right? Like a gallstone slips out of the gallbladder and wedges itself tight into the common bile duct.
That's a very common one. Or something much more insidious, like a tumor. Pancreatic cancer can physically grow against the outside of the bile ducts and basically pinch them shut, like stepping on a garden hose.
You also see this in patients with a history of major abdominal surgery, don't you?
You do. The body heals by forming scar tissue, and sometimes that scar tissue forms a stricture, which slowly tightens around the bile duct until nothing can get through.
Here's where it gets really interesting to me. To the naked eye, a patient walking into a clinic just looks yellow. It's the exact same visible symptom.
Exactly.
But underneath, it's stemming from 3 entirely different mechanical failures, like a blood explosion, a failing organ, or a blocked pipe. You can't just look at the yellow skin and know the cause.
No, you really can't. You have to play detective. Clinicians have to look for secondary clues, specific physical manifestations, to figure out which of the three failures is actually happening.
Let's talk about those clues. Because the underlying failures are different, the external symptoms vary in these fascinating ways. First, a question that I know patients ask all the time: why do the eyes always seem to turn yellow first, way before the skin does?
That comes down to basic biochemistry. Bilirubin has a very high affinity for a specific protein called elastin. It binds to it almost like a magnet. And it turns out the sclerae, the whites of your eyes, are incredibly rich in elastin. So as soon as bilirubin levels start to creep up in the blood, it gets pulled directly to the eyes. You will see scleral icterus, which is the medical term for yellow eyes, before you see it anywhere else on the body.
That makes perfect sense. Now let's talk about the bathroom, because the texts mention major changes in urine and stool, specifically for that plumbing problem, the post-hepatic obstruction.
Yes, this is a crucial distinction that relies on really knowing the assembly line. Remember the difference between unconjugated and conjugated bilirubin.
Right, raw versus water-soluble.
Exactly. In an obstructive jaundice, the bilirubin has already been processed by the liver. It's conjugated, which means it is water-soluble. But because the pipe is blocked, it backs up into the blood.
And because it is water-soluble, your kidneys can suddenly filter it out.
They filter it out and dump it directly into your bladder. It spills over into your urine, turning it a very dark tea or cola color. Yet patients will frequently press the call button in the hospital in an absolute panic, asking the nurses, why does my urine look like Coca-Cola? This is why. The kidneys are just trying to vent the pressure.
Seeing that in the toilet at 3 a.m. would be absolutely terrifying. But at the same time, because that intestinal pipe is blocked, the bilirubin never reaches the gut.
Right. And remember we said earlier that a byproduct of bilirubin stercobilin is what gives stool its normal brown color.
Oh, right. So if the bile duct is completely blocked,
Zero stercobilin is made in the gut. The result is stool that looks shockingly pale, almost like gray clay. So dark urine combined with pale stools strongly points toward a post-hepatic obstruction.
I want to highlight another symptom of obstruction that completely surprised me in the readings. It's not visual at all. It's the itch. Pruritus.
Oh, yes. It is severe, maddening itching. When those bile ducts are blocked, it isn't just bilirubin that backs up. Bile salts back up, too.
And they get into the skin.
They deposit right into the skin and trigger intense nerve irritation. Imagine, like, the worst mosquito bite you've ever had, multiply it by 1,000 and spread it over your entire body.
That sounds awful.
It is. Patients will scratch themselves raw trying to find relief. Managing that itch is a massive nursing priority for cholestatic patients.
So those are the clues for a plumbing obstruction. What if it's a processing problem? A sick liver.
Well, for hepatic jaundice, you see more systemic whole-body signs of a failing organ. Profound fatigue, malaise, nausea.
Just feeling generally terrible.
Right. Sometimes there's a dull, continuous ache in the right upper quadrant of the abdomen, which is actually the capsule surrounding the liver stretching because the organ is just so inflamed.
And for our production problem, the prehepatic blood breakdown.
You might actually feel an enlarged spleen, a condition called splenomegaly. The spleen is basically the graveyard for red blood cells, so if it's working overtime to clear out a massive amount of destroyed cells, it physically swells in size.
We absolutely need to pause right here and highlight the red flags, the life-threatening signs that require immediate provider notification. Because if you or someone you know is yellow, what is the symptom that means call an ambulance right now?
The absolute biggest red flag is fever. If a patient has jaundice, right upper quadrant pain, and they suddenly spike a fever, that is a classic triad. It's known as Charcot's triad.
Okay, Charcot's triad.
Yes, and it points directly to an infection in a blocked bile duct, a condition called cholangitis.
Because stagnant fluid breeds bacteria, right?
Always. The pipe is blocked, the bile just sits there, bacteria multiply, and because the pressure is high, those bacteria can be rapidly forced backward into the bloodstream, causing lethal sepsis.
So fever plus jaundice is an absolute drop-everything emergency requiring immediate IV antibiotics and intervention.
Exactly. Do not wait.
So what does this all mean for the doctors? Let's bring all this theory into the real world. Let's look at how doctors definitively prove these suspicions using diagnostics because, physical clues and patient histories only get you so far. How do doctors look at blood tests to pinpoint the exact bottleneck?
What's fascinating here is they rely on the elegant logic of liver function tests, or LFTs.
Hmm.
These blood panels don't just tell you the liver is sick, they actually tell you how it is sick by looking for specific enzymes.
Okay, slow down for a second because this is where I always get mixed up in the alphabet soup of labs.
Yeah.
You've got AST, ALT, ALPGGT. Just walk me through this.
Sure. Think of them as different biological alarm systems. AST and ALT are enzymes that live inside the liver cells, the hepatocytes.
Okay.
If the blood panel shows astronomically elevated AST and ALT, that tells you the liver cells are actively dying and bursting open, literally leaking their internal contents into the blood. That confirms a hepatocellular or processing injury.
Oh, like our patient who took too much Tylenol. The factory floor is on fire, so the AST and ALT alarms are ringing.
Yeah. Perfect analogy. But what if the AST and ALT are basically normal, but two different enzymes, ALP and GGT, are shooting through the roof?
That means something else.
Right. It tells a completely different story. ALP and GGT are enzymes found specifically in the cells that line the plumbing, the bile ducts. When the duct is blocked and under high pressure, those pipe cells get irritated and overproduce ALP and GGT.
Ah, I see. So ALP and GGT are the plumbing alarms. High ALP means a post-hepatic obstruction.
You got it. And for our prehepatic production problem, where the red blood cells are blowing up, you wouldn't necessarily see massive spikes in liver enzymes at all. You'd look for hemolytic markers.
Yeah. The sources mention a few of these: reticulocytes, LDH, and haptoglobin. What are those telling us?
Well, reticulocytes are immature baby red blood cells. If that number is high, it means the body is frantically pumping out new cells to replace the ones being destroyed.
And LDH.
LDH stands for lactate dehydrogenase. It's an enzyme found inside red blood cells. When they explode, LDH spills out into the blood, so high LDH means high cell destruction.
And what about haptoglobin? That one sounded weird.
Think of haptoglobin as the biological cleanup crew. Its entire job is to float around and bind to free-floating toxic hemoglobin that spills out of ruptured cells.
So if there's a lot of destruction.
If your haptoglobin levels drop to near zero, it means the cleanup crew is entirely overwhelmed and used up.
Right.
There's just too much destruction happening.
Okay, so blood tests give us the biochemical fingerprint. But especially for those plumbing obstructions, we need to actually see the blockage. Let's outline the standard diagnostic workflow for imaging.
The first-line defense, almost universally, is a right upper quadrant ultrasound. It's fast, there's no radiation, and it's phenomenal at spotting solid objects like gallstones.
And it shows if things are backed up, right?
Yeah, it shows if the bile ducts above the liver are dilated, which instantly implies a backup.
But if the ultrasound shows a backup but can't see the cause, say they suspect a tumor hiding behind the stomach, they escalate, right?
They do. They move to a CT scan or an MRI. These provide high-resolution, cross-sectional views of the pancreas and the surrounding anatomy to spot any hidden masses compressing the plumbing.
The clinical guidelines also dedicate a lot of space to two very specific advanced tools for looking at the biliary tree, MRCP and ERCP. They sound identical, but they are used very differently.
They are crucial to distinguish. MRCP stands for magnetic resonance cholangiopancreatography. It is essentially a highly specialized MRI. It is purely diagnostic. You lie in a tube, and it takes gorgeous, detailed 3D pictures of the bile ducts without ever invading the body.
So it's just a camera, but ERCP is different.
Very different. ERCP stands for endoscopic retrograde cholangiopancreatography. This is an invasive procedure. A gastroenterologist passes a flexible tube with a camera down your throat, through your stomach, and right into the tiny opening of the bile ducts in your intestines.
Oh, wow.
Yeah, and ERCP isn't just for taking pictures, it is interventional.
Which perfectly brings us to taking action, because, as we established earlier, jaundice isn't the disease. You don't treat jaundice with, like, anti-yellow pills. You target the root cause.
Exactly. This raises an important question of how we tailor our interventions. Let's break down the tailored medical interventions for each of our 3 Ps, starting with the production problem. Prehepatic jaundice. The red blood cells are breaking down too fast.
Right. The liver is fine, so we ignore the liver and manage the blood. If it's an autoimmune disorder attacking the cells, you give immunosuppressive drugs.
Exactly.
If the patient has lost too many cells, you administer blood transfusions to keep oxygen flowing. Or if it's malaria, you aggressively treat the parasitic infection.
And once you stop that massive influx of raw material, the healthy liver will quickly clear the remaining bilirubin, and the jaundice will just fade on its own.
What about the processing problem, hepatic jaundice, where the liver factory is failing?
This is often the most complex to manage. because you have to support a failing organ while it tries to heal.
Right.
If it's a viral hepatitis, you might deploy antiviral medications. If it's autoimmune, corticosteroids to bring down the inflammation. But very often, the primary treatment is simply removing the offending agent.
Like mandating complete abstinence from alcohol or immediately halting hepatotoxic drugs like our acetaminophen example.
Yes. Then, the medical team has to meticulously manage the dangerous complications of a failing liver. The liver makes your clotting factors, so if it fails, you have bleeding disorders.
Oh, that's dangerous.
Very. And the liver filters ammonia, so if it fails, toxins build up in the brain, causing severe confusion called encephalopathy. In cases of severe, irreversible, acute, or chronic liver failure, the ultimate final intervention is a full liver transplant.
Wow. And finally, the plumbing problem. Post-hepatic obstructive jaundice.
You have to clear the pipe. This is where that ERCP procedure really shines. If the ultrasound found a gallstone wedged in the common bile duct, the doctor uses the ERCP endoscope to literally reach into the duct with a tiny basket, grab the stone, and pull it out.
Just like that, the flow is instantly restored.
Exactly.
But what if the blockage is a tumor pinching the duct shut?
They can use the ERCP to place a tiny plastic or metal tube called a stent inside the duct to forcefully prop it open against the tumor.
Oh, I see.
Long-term, it may require major oncologic surgery to remove the mass entirely. And remember our red flag. If that blocked duct is infected cholangitis, they need massive doses of IV antibiotics running immediately alongside unblocking the duct.
And throughout all of this, regardless of the underlying cause, the nursing staff is providing critical supportive care, keeping the patient hydrated, ensuring they're getting adequate nutrition when they feel nauseous, and, like we mentioned, aggressively attacking that intense pruritus.
Yes, they'll use medications like cholestyramine, which actually binds to bile acids in the gut so they can be pooped out instead of absorbed into the skin. Or they'll prescribe heavy antihistamines just to help the patient sleep through the maddening itch.
We have covered an immense amount of ground today. To summarize the journey for you, jaundice is simply a window into your body's bilirubin metabolism. By remembering the 3 Ps: production, processing, and clumming, you can quickly organize the chaos.
It's a great mental framework.
It really is. It's either an overproduction of waste in the blood, a failure of the liver's processing factory, or a blocked exit route in the plumbing. By understanding the normal physiological process, how old hemoglobin is dismantled, bound to an albumin delivery truck, chemically conjugated in the liver to become water-soluble and excreted, you can see exactly why a breakdown at any stage causes that telltale yellow sign.
Everything traces back to that pathway.
We've traced the clues from dark urine and clay-colored stools to the precise LFT alarms and imaging tools that solve the mystery. And for you listening, understanding this process takes the mystery out of a very alarming symptom. You now know what questions to ask your doctor, and you know the red flags to watch out for.
I do want to leave you with a final thought to mull over, something that pushes beyond just looking at jaundice as a sign of disease.
Oh, what's that?
Well, we've spent this entire time talking about bilirubin as toxic waste that needs to be cleared. But modern research is uncovering something fascinating. There is a very common, harmless genetic condition called Gilbert syndrome.
I've heard of that.
Yeah, where people naturally run with slightly elevated levels of unconjugated bilirubin. They might turn slightly yellow when they are stressed or fasting.
But it's not dangerous.
No, for decades, doctors just dismissed it as a benign quirk. But large-scale studies are now showing that people with Gilbert syndrome actually have significantly lower rates of cardiovascular disease.
Wait, really? Why is that?
It turns out, in mild controlled amounts, bilirubin acts as a powerful evolutionary antioxidant in the bloodstream, actively protecting your blood vessels from damage.
Wow. So the very substance that turns you neon yellow when it builds up uncontrollably might actually be quietly protecting your heart when it's just slightly elevated.
It is a profound reminder of how complex our biology is. The body rarely creates a molecule for only one reason.
It's all connected, and there is always another layer to uncover. Until next time, keep diving deep.